Hello everyone, welcome back. तो चलो शुरू करते हैं आज का एकदम high yield session. In today's explainer, we are going to crack one of the absolute most critical topics for your exams, and that is twin pregnancies. अगर आपने ये masterclass ध्यान से follow की, your concepts on chorionicity, embryology timings, and complications will be crystal clear. I promise you by the end of this, you'll be solving MCQs in your sleep. Let's get right into it.
Here is our roadmap for today. First, basics and definitions. Then, the all-important rule of time for embryology. Third, the clinical matrix comparing DCDA, MCDA, and MCMA. Fourth, we'll hit those crucial USG markers. And finally, conjoined twins and their complications. Let's dive in.
All right, Section 1, Basics and Definitions. Let's clear up the foundational stuff that always trips people up.
Okay, first up, let's distinguish between two terms that sound super similar but are totally different. Superfecundation. This is when two ova are released in the exact same cycle, but they get fertilized at different times by different acts of coitus. It's rare, but yeah, it happens in humans. Then we have superfetation. This is when two ova are released and fertilized in entirely different cycles. The books say it's theoretically possible until about 14 to 16 weeks, right up until the uterine cavity is completely obliterated. Now, practically speaking, you're almost never going to see this in humans. But you know how it is. Agar exam mein theoretically possible likha hai, to you absolutely have to know it.
Moving on to zygosity. Think of dizygotic twins as your standard fraternal twins. Two separate ova, fertilized by two separate sperms, forming two distinct zygotes. These are way more common, and they can be the same or totally different sexes. But check out monozygotic twins. X single ovum, X single sperm. They form one single zygote that splits later on. Less common but super fascinating because they share the exact same genetic material. Same sex, same blood group, same HLA typing, same phenotype. Everything is identical. But, and examiners absolutely love this trick, what is the one thing that's different? Unke fingerprints. Yup, even identical twins have different fingerprints. Mark that down.
Let's talk numbers, because exam mein seedha question aata hai yahan se. Mark this. The incidence of twins in India is exactly 1 in 80. Just to give you a little global perspective, Nigeria has the highest incidence at 1 in 20, and Japan is way down there with the least at 1 in 200. But for your NEET PG exams, 1 in 80 is the magic number you need to remember.
So what do we actually do with that 1 in 80 figure? We plug it into Helen's rule. This is a brilliant little shortcut to calculate the incidence of higher-order multiple pregnancies. If the incidence of twins is 1 in 80, Helen's rule says you just take that denominator and multiply it by itself. So triplets ka incidence kya hoga? Simply 1 in 80 squared. Quadruplets, 1 in 80 cubed. See, it's that simple. Pure math.
Section 2, The Rule of Time in Embryology. Timing is literally everything here.
We established that monozygotic twins come from one zygote dividing. But when does it divide? This timeline is absolute gold for your MCQs. The number of chorions and amnions depends 100% on the exact time of division. If it divides super early, less than 4 days at the Moriola stage, you get DCDA, dichorionic, diamniotic. Everything is completely separate. If it divides between 4 to 8 days, right at the blastocyst stage, they share a chorion but have separate amnions, so MCDA, monochorionic diamniotic. Ab batao, agar division 8 se 12 din ke beech hua, to kya banega? It becomes MCMA, monochorionic, monoamniotic. They share absolutely everything. And if the division is delayed beyond 12 days, the embryonic disc is already formed, so you end up with conjoined or Siamese twins. You've got to lock this 4-8-12 rule into your brain.
Moving to Section 3, the clinical matrix comparing DCDA, MCDA, and MCMA.
Let's compare these clinically. In DCDA, each twin has its very own amnion and chorion. So, if you're looking between the two babies, there are literally 4 layers: amnion, chorion, chorion, amnion. On ultrasound, this separating membrane is thick, greater than or equal to 2 millimeters. In MCDA, they share the outer chorion but have their own inner amnions, so just 2 layers separating them, amnion and amnion. Naturally, this membrane is thin, less than 2 millimeters. And in MCMA, they are chilling in the exact same sac. 0 layers between them. No separating membrane whatsoever.
And this setup brilliantly illustrates why chorionicity dictates the entire prognosis. DCDA twins have no shared vascular connections. The prognosis is great, and you can comfortably deliver them around 38 weeks. But MCDA twins, they have a single shared placenta with deep vascular connections. ये deep connections ही problem create करते हैं, leading to twin-to-twin transfusion syndrome, or TTTS. Because of this high risk, we pull them out earlier, at 36 weeks. Now look at MCMCA. They actually have superficial vascular connections. So the biggest specific complication here isn't actually TTTS, it's cord entanglement, which can tragically lead to the sudden intrauterine death of both twins. It's so high risk that management demands strict corticosteroids for lung maturity and an early C-section delivery between 32 to 34 weeks. The thumb rule: monochorionic means bad prognosis, dichorionic means better prognosis.
Section 4. USG markers. Let's see what we're looking for on the screen.
Timing is just as crucial on the ultrasound machine. The earliest you can assess gestational age is 7 weeks, but the absolute best time to determine chorionicity, which, as we just saw, dictates your whole management plan, is between 10 to 14 weeks, right in the first trimester. Do not forget this range. Also, if you're scanning in the second trimester and you spot an increased nuchal translucency, or NT, you need to strongly suspect twin-to-twin transfusion syndrome.
So what exactly are we hunting for on that 10 to 14 week scan? When looking at the ultrasound for DCDA twins, notice the twin peak or lambda sign. You see how there's this thick wedge of placenta intervening right between the chorions? That is your classic lambda sign. Now contrast that with MCDA twins, where we see the T sign. It's a single chorion, a super thin separating membrane, and 0 intervening placenta. It literally looks just like the letter T. Basically, if you see a lambda sign, you can breathe a little easier. It's DCDA.
Finally, Section 5. Conjoined twins and their complications.
This leads us to conjoined twins, the ultimate complication of extremely late division in monoamniotic pregnancies. We classify them based on exactly where they're joined. Thoracophagus means joined at the thorax. Reciphagus is joined at the vertebral column. Chroniophagous, joined at the head, is thankfully the least common. But what is the most common type? Examna directhidotaya, paraphagus. This means they are joined at the lower abdomen and pelvis. As for the management pipeline, it is strictly planned. You absolutely must administer a complete steroid course for lung maturity, followed by a scheduled cesarean section between 32 to 34 weeks.
All right, we've covered incredible ground today, from the 4-8-12 rule to the classic lambda and T signs. But before we wrap up, I want to leave you with a conceptual bouncer. Think about this. Agar MCA twins main B vascular connections hen, superficial wale, then why is twin-to-twin transfusion syndrome actually less common in them compared to MCDA twins which have deep connections? What is the underlying hemodynamic logic here? Ponder over that. We are going to decode this exact mystery in part 2 of this explainer series. Until then, keep revising, keep